Okay. Good morning, everybody. I've been given the task and the opportunity to talk about the gorilla in the room, the gorilla in the virtual room, not a 600-pound gorilla, but a 600-ton gorilla, which is COVID-19, which has transformed all of us and all of our lives. In half an hour, I only really have the opportunity to give a very high-level view. And as Jim mentioned, there's an archive of podcasts that Siri and I have had, and with others, in discussing this over the past few months. So let's get started. The coronaviruses are viruses that have been around for millions of years, maybe hundreds of millions of years. And they mostly live within other life forms. Some other mammals, in particular bats, are a known host for the coronaviruses. It's important to note on the left of this slide, you see a family tree of the coronaviruses, and they are split by their genetic formulation into different subfamilies. And you'll notice these four that are outlined here, human COVID viruses with certain nomenclature, which have already been found in human beings for a long time. They've adapted to us. And by and large, they don't cause much of a problem. They cause common colds. People estimate 10 to 30% of seasonal common colds are due to coronaviruses. So coronaviruses are not completely original. But in the bottom left of this slide, you see the beta coronaviruses, which is a subfamily that contains some viruses which jumped from other mammals into human beings in recent years, starting around 2002 with the SARS virus, which caused an outbreak in Southeast Asia that was largely contained with only several thousand deaths worldwide. And then later in 2012 in the Middle East and Saudi Arabia, another coronavirus changed and was able to jump from camels into human beings, and then it's still there, but it's been largely controlled with, again, just a few hundred to a few thousand deaths. And then, of course, at the end of 2019, people in China noticed a new form of pneumonia in the city of Wuhan. And when this virus was sequenced very shortly afterwards, it was found to be highly related to the SARS virus and was named SARS-CoV-2 to indicate that relationship. And on the right-hand side, you see the basic structure of this virus. The genetic material, unlike human beings, is RNA. It's not DNA. It's an RNA virus, which indicates perhaps that RNA has been around even longer than DNA. But the RNA is able to replicate itself once it's inside a cell, a particular kind of cell, and is able to replicate and produce more of itself, which is sort of the aim of the virus. The virus is not really alive without being inside of a cell. To get into the cell, it has to find a way to enter. And in the case of coronaviruses, these kind of red spikes that you see here, or corona, are the attachment factors or proteins. And I'll be talking more about this spike glycoprotein. But you'll also notice several other proteins which are indicated in that cartoon. And it's important to note that the immune system can recognize all these elements. And part of the difficulty that we've had since this virus was first described was figuring out what the target should be to try and produce immunity to the SARS-CoV-2 virus. So how does it actually attack the body? This was worked out very quickly after the virus was identified and the sequence was known. And it was discovered that the spike protein is able to bind to a protein present on the surface of many cells in the human body. So we see a cell here. This is the cell membrane. The outside of the cell is on top, the inside on the bottom here. And the cell is expressing this protein called ACE2, which stands for angiotensin converting enzyme 2. And it turns out that a portion of this spike protein is able to bind to a portion of the ACE2. But it's only able to do so after it's been modified by enzymes that are present also in the human body, some of which are also on the surface of these cells. And this one that you see here is an important one that is able to act as an enzyme on the spike glycoprotein, change its conformation, and allow it to attach with a very high degree of binding, a high affinity as it's called, to the receptor. And that allows it to get into the cell. So these ACE2 expressing cells have been found in many tissues of the body, as I'll mention in a little bit more detail later. Once the virus enters the cell, it's then able to break out of the vesicle that it enters within and is able to release the genetic material, which is then put into proteins, basically hijacking the machinery of the cell to do that, reassembling the virus particle, and eventually causing the cell to release it, usually through cell death. So you get a single cell with hundreds or thousands of these viral particles being released in a continuous process, and that's the life cycle of this virus. One of the questions that's come up since we've discovered it is this virus mutating? Is it changing? Is it becoming less lethal or more dangerous? And in general, a very intensive world effort to look at the viral genomes is ongoing, with thousands and thousands of different virus isolates being looked at. One thing that's emerged of probable clinical relevance is a change in the virus that has resulted in a possible increase in its infectivity and its ability to get into the cells. And we think that's true because of this sort of evolution of one form of the virus into the current form over time, which is shown on the top here. And on the bottom is cartooned the fact that this G614 mutant or change in the virus seems to be able to infect cells more easily. So possibly one element of the pandemic that we've experienced has been an actual increase in the ability of the virus to be transmitted. How is it transmitted? Again, this has taken time to work out. It started with a recognition that as a respiratory virus causing pneumonia, that it must be spread through droplet transmission, people sneezing, coughing, yelling, screaming, talking. But also we know that these droplets don't have to necessarily be inhaled. They can settle on surfaces, and that led to a concern with surface or fomite transmission, where the virus can get picked up by touching a surface and then touching your fingers to your eyes or your nose or your throat. And we've also learned that the virus can actually possibly be transmitted through a fecal-oral route. That is, it's been found in stool and in the bathrooms of infected individuals. And so this is a concern that as yet has not really caused major concern, but should be kept in mind. One of the most important issues that has been tough to really nail down is how big do these droplets need to be? Can they be very tiny? And that's called aerosols. These very tiny aerosols, unlike droplets, don't sort of settle within seconds to minutes, but can stay in the air from minutes to hours. And I have to say that the evidence that's emerged has been quite clear that aerosol transmission is a mode of transmission of this virus, which makes it more dangerous and more transmissible. The other very important piece of transmission that needs to be emphasized, and you've probably read a lot about this, has been the fact that we now understand that unlike a lot of other viruses, it can be transmitted by people who do not know that they are sick. And in terms of semantics, you can call that transmission asymptomatic or pre-symptomatic. Some people that transmit the virus never feel any symptoms. And probably a majority who transmit it later develop symptoms. So if you combine these groups of never symptomatic or pre-symptomatics, you find that a large portion of people transmitting the virus don't know they have the disease at the time they're transmitting it. In general, about 40%. In some studies, it's been the majority. So this is clearly a very important piece and plays into the urgency of public health measures to prevent transmission. It's a respiratory virus, so it's not the only respiratory virus. I already mentioned the other human coronaviruses, which long ago adapted to being in people and are generally just nuisances causing colds. But we have all these other viruses that affect different areas of the respiratory tract, from the upper respiratory tract with the rhinovirus to the lower respiratory tract with the RSV virus and the human metapneumovirus. And influenza, of course, doing both. And SARS-CoV-2, like SARS, is a disease that when it causes real illness is mainly focused in the lungs, but we also know it causes upper respiratory symptoms. So it's a respiratory virus, but that's not the end of the story. We've learned more about it. We've seen all these other tissues in the body that can express this receptor, which is outlined here. So you see that in the nose, particularly the cells that are specialized for smell in the epithelium express this receptor. And that may be one reason why people who catch this disease often report loss of smell or taste. It's present on the tongue, in the keratinocytes, which is a cell in the tongue. Of course, all the rest of the respiratory tract, both in the conducting airways, in the ciliated cells and other cells in the airways called club cells, but also very, very deep in the lung, in the air sacs, the type 2 pneumocytes, which are involved in secreting surfactant and are important in lung function, in exchange of oxygen for carbon dioxide. We see it in the GI tract. We see it in the kidney. We see it in other cells. So this is perhaps some basis for understanding why this disease causes so many different problems. We see it in the heart, and we're now aware that a majority of people who get this disease have heart damage from it. So it's sort of taking highways and byways throughout the body through this receptor relationship. And we also know that cells in blood vessels, the endothelial cells, the cells coating small blood vessels, can and do display the ACE2 receptor and can be primarily damaged directly by infection with the virus. So this is what has led to this tremendous variability in clinical problems that result from getting infected with SARS-CoV-2. One thing that I'd like to really emphasize is that there is a relationship between the dose, the degree of exposure and the outcome. And this is a study which clearly shows that in looking at death as an endpoint, we see that as a function of the viral load as determined by testing of cells from the body, that there's a clear relationship between how much virus you have in your body and what the outcome of the disease is. And so one of the factors in thinking about whether or not you get sick, we know most people who get infected either have no symptoms or mild symptoms, may have to do with the degree of exposure. And if you think about that, think about the people who are getting sick, healthcare workers, people that have high density jobs or families, essential workers. All these things play into the probable degree of exposure. So what about some of these risk factors? Probably the one that's best known, it certainly came out in China, and then Italy certainly confirmed that, was that there's this very striking relationship to age. And most of the severe illness is related to people who are over 60, particularly those over 80. There's a very sharp upward trend in risk for death as one gets older. That doesn't mean that younger people cannot get seriously ill and die. We've certainly seen enough reports of that in the media. But on a population basis, age is probably the most important single risk factor. And that, of course, plays into how we deal with this on a public health basis. Beyond age, we then see this tremendous effect of ethnicity and race. And this has really come out in the United States, where we have this multiracial, multicultural society. And we see this tremendous disparity between the cases that occur in whites versus blacks and Latinos, which is clearly shown on this data from the CDC. What about the symptoms? On the left of this slide, you see the main symptoms. You're probably familiar with that: fever and respiratory symptoms like shortness of breath, cough, which is usually a dry cough, but can be a wet cough, fatigue, confusion, muscle aches and pains, diarrhea, nausea, vomiting, chest pain. These are some of the most common symptoms. I would add to this particular study, which didn't look at it, the loss of sense of smell and taste. And on the right-hand side, you see the major comorbidities that turn up again and again in studies around the world. Heart disease being very important, diabetes, very important, chronic lung disease, and kidney disease. These are all major things. In many studies, obesity emerges as extremely important and in proportion to the degree of obesity, I should mention also. And these comorbidities are very strongly linked to outcome. So again, using CDC data, we see that the risk of hospitalization is 7 or 8 times greater in those with these comorbidities than in people that don't have them. And even more striking, over 10 times higher death risk for people with these comorbidities. So that, of course, makes us focus as a CF community on the fact that chronic lung disease is one of the comorbidities listed. Recently, the CDC revised its list of these comorbidities, which they call risk factors, which you see on this slide adapted from their webpage. And in addition to things which, as a CF community, we need to pay particular attention to, besides the lung disease, the immunocompromised state of people that have had lung transplants or liver transplants, and people with diabetes as a complication of their CF. These are particular things that we need to pay attention to. But on the bottom half, you see these other potential diseases or disease states that might be at increased risk, and CF is specifically listed as one of them. Why isn't it listed as a definite? Well, we just don't have the data. We haven't had enough systematic studies of CF as a relatively rare disease in the world compared to things like COPD and asthma. But how does lung disease play into this risk factor? Well, one thing has to do, and I think this could be important in the overall picture, is the expression of the receptor, the ACE2 receptor. And on the top left, what you see there is a study which showed the expression of ACE2 at different age groups. And you can see that in kids under 10, the ACE2 expression is significantly lower than it is in adolescents or young adults. And it's possible, and this is a speculation, that this is one reason why kids under 10 seem to have less disease, because they may have less expression of the receptor. The rest of the slide shows some other lung diseases. So you see here chronic lung disease, higher expression of ACE2 in people with COPD, higher expression in people with pulmonary artery hypertension, and in smokers, especially those that also have COPD. And we know smoking is a major risk factor for the development of COPD. What about asthma? Well, asthma is of interest, I think, in general as another lung disease, but also remember that about 1/3 of people with CF carry a formal diagnosis of, secondary diagnosis of asthma, at least as reported by the CF Foundation Patient Registry. So what about this comorbidity? This is one of a number of studies which have produced somewhat varying results about asthma as a risk factor, but I think what's interesting here is if you look at it, the risk seems to be mainly in people with a non-allergic form of asthma as opposed to people with the allergic form of asthma, which is about 50-50 in adults and about 1/3 of kids who don't have allergic asthma as the basis of their asthma. And you notice that this risk is even increased if there's concomitant COPD. So asthma certainly should be considered as one of the significant risk factors, particularly if it's non-allergic. Now, turning to public health, I think this slide shows as well as any that I've ever seen the failure of our country to deal with this disease. Look at the comparison between the United States and the European Union, a union of about 450 million people, which has flattened the curve, which has crushed the cases. There's no miracle involved here. The difference has been in public health. The difference has been in social cohesion. The difference has been in societies willing to accept the advice of scientists versus those that have a strong anti-science, skeptical, conspiracy-minded segment of the population. So from a similar peak, which occurred about 2 weeks earlier in Europe compared to the United States, we have a markedly different situation. And starting in June, we have this tremendous takeoff of cases in the United States, primarily in states that had premature reopening, that never shut down with high compliance. And we're now at the case where we're between 50 and 70,000 cases a day and over 1,000 deaths a day in the United States, whereas certain countries in Europe, deaths are measured in the tens rather than in the thousands. And what are these public health measures? This is not rocket science. This has been worked out. It was implemented a century ago in the response to the Spanish flu pandemic. What you need to do is to create social distancing, physical distancing between people. You need people to wear masks to reduce transmission. You need to identify cases. You need to isolate cases and contacts, and you need to quarantine them for the infectious period of time. And this was exactly what the Chinese did successfully, as shown here. So on the y-axis, we have what's called the reproduction number, which is on average the number of other people infected by a single case. So that number at the start of the pandemic was between 2 and 3, and in some studies it's been as high as 5. but if we accept it as around 3 or so, we see that before the implementation of public health measures in China on January 23rd, the epidemic was out of control. But then with the lockdown of Wuhan, the suspension of traffic, the quarantining of the population with stay-at-home orders, followed by case identification and quarantining and improvement of medical resources with construction of field hospitals. And finally, in China, with centralized quarantine, where people actually were removed from their homes and put into communal quarantine facilities until they were non-infectious, the Chinese were able to get a handle. Now, that doesn't mean the disease is gone. The disease is still around and outbreaks still occur. But in general, the mitigation measures of finding and isolating cases and quarantining them is able to keep a handle on this. And this is what's out of control now in our country. Let's turn to treatment. A number of treatments have been looked at, a large number. So far, only 2 measures that have been found specifically and effective really in hospitalized patients. The antiviral drug remdesivir, which is shown down here. It inhibits one of the enzymes necessary for the replication of the virus. And a steroid, dexamethasone, which is widely available and also has been found to be helpful in hospitalized people. The only other thing I'll mention about this particular cartoon, which came out in early March, was that hydroxychloroquine and chloroquine were under intensive study and have since the verdict has come in. We now know quite clearly that these drugs are ineffective. On the right-hand side, you see what I think is the most hopeful treatment option that's going to be emerging in the next few months, and that is to use products of the immune system to treat the virus. And you can do this by taking blood from people that have recovered, purifying their plasma, or purifying even more into hyperimmune globulin. And best of all, you can actually manufacture under industrial conditions purified monoclonal or single antibodies. As long as it's to the right target, it can prevent the entry of the virus into the cell. The average course of the disease we see here. This incubation period, you can see, varies very greatly. The average is about 5 days, but there is a long tail. Some people can be carrying the virus for up to 3 weeks before developing symptoms. Luckily, it's only about 5 days on average, but this 5 days, of course, is plenty of time to spread the virus. Imagine if you go and get tested and you don't know the result for 7 days or 10 days or 14 days, which is the case for a lot of people in this country. You might as well not have been tested because you can spread the virus during that pre-symptomatic period. Then you get symptomatic and you have what most people experience was a fairly mild acute phase, with some people progressing about 20% to this highly inflammatory phase of the disease, which is associated with most of the bad outcomes. And somewhere around 10 or 14 days, the immune system kicking in with the production of antibodies and T cells that are capable of reacting against the virus. I think I'll skip this cell. This is really for clinicians, just emphasizing that we switch from this early viral phase to a later host inflammatory phase, which is really the phase that's associated with most of the serious outcomes. And then the things that doctors use and healthcare providers use to look at clinical symptoms, clinical signs, and various drug therapies. I've X'd out chloroquine and hydroxychloroquine since the publication of this particular paper. As I mentioned, antibodies then kick in at about 10 to 14 days. And there are 2 forms of antibodies that are widely looked at. One is called IgM, which is an earlier type of antibody response that tends to go away fairly quickly, and the longer-lived IgG response, which tends to linger, although it does go down over time. We know that there's differences between people depending on what particular antibody specificity you're looking at, and between individuals in terms of the amount of antibody, which probably is related to viral load also. The immune response, though, is more than just antibodies. Besides the arm of the immune system that produces antibodies through these B cells, we have these T cells, some of which become killer T cells that can destroy the virus directly. And as you read in the media about antibodies, and there's been so much talk about antibodies and serology and vaccination, remember that it's possible that the T cells might be playing as important, perhaps even a more important role in protection against the disease. We know this because when we look at the disease production of cold viruses that don't cause serious disease, we're able to form a very high early response with chemicals called interferons that are produced by cells of what's called the innate or early immune system. And the successful ability to produce these interferons means that we don't have to rely so much on chemicals that call in the rest of the immune system, these chemokines or cytokines. Whereas with COVID, we have a particular ability of this virus, it seems, to suppress the ability of the body to produce these interferons. And that calls into play much higher levels of these other chemicals or cytokines, chemokines, that then kick off this hyperinflammatory phase. So besides the antibodies, which recognize various components of the virus shown here, we have these killer T cells, which the majority of people who are infected produce, again, against all the components of the virus. And in particular, we think the most important against the spike protein and particularly the receptor area. One thing that's very interesting, which I wanted to show here from this study, was that a certain number of people who have never been exposed to the COVID virus can actually be found to have some production of antibody and production of killer T cells against the virus. And we think that may be due to some cross-reactivity resulting from exposure to common cold viruses. So it's possible that children who are exposed to a lot of these coronaviruses that cause colds may have developed some form of immunity based on memory B cells and T cells. We don't know that for sure, but that's one of the things to consider. We have a very big pipeline of many vaccines, over 160 that are in development, many antiviral compounds that are either in clinical testing or about to be, and many other treatments. On the bottom half of the slide, you see this progression of these viral candidates into various phases of clinical trials. And in fact, we already have one vaccine in China that's been approved for use in the military. So for the next year, people in the Chinese military are already getting this vaccine to hopefully protect, and they'll be deployed, of course, in the public health measures ongoing in China. I don't have time to spend on this, just to illustrate the fact that there's lots of different ways to make a vaccine, and virtually all these methods are being looked at by different academic labs and certainly different pharmaceutical and biotech companies to produce different kinds of vaccine. And you can boil them down to these different categories shown here. The most important thing we think is to produce an antibody against this receptor binding domain of the spike glycoprotein to prevent the entry of the virus into the cells. And all of these different techniques may be available to do that. But who's going to win and what's going to be the end result, we don't know. We have to go through this long process of manufacturing these clinical trials. We now have phase 3 trials of at least 3 or 4 different vaccines in different countries, including at least 2 in the United States. And then this whole area of how are you going to scale up to produce hundreds of millions or even billions of doses. Let's finish by just discussing for a few minutes CF. This was a survey that was done in Europe of people with CF. They got almost 1,000 responses from 31 different countries in the European Union. I just want to emphasize the perspectives here that most people with CF feel threatened. And I think that's a very realistic way to be. This is a very highly transmissible virus. CF almost certainly is an independent risk factor. And we don't know a lot about other facets of how CF interacts with this virus. Many people fear that treatments may become available, and the majority do feel that their health has been downregulated, has been affected detrimentally by the pandemic. Very reasonable. The data that we have are beginning to emerge around the world. I've summarized some of the data now at the top at the UK. We have 27 cases as of July 20th, and we see a very wide range of FEV1 and age of patients. The good news here, most of the patients, 26 out of 27, have recovered, only 1 death. And then when we turn to the CF registry, we have, as of just earlier this week, over 2,000 patients have been tested, 122 positive cases reported. About a third of these are pediatric cases. The majority of those have been adults, and hospitalizations have also occurred in about a quarter of the cases, but only 2 deaths, one in a patient with advanced lung disease and one in a transplant patient. In Europe, in the European Union, we have another 122 cases reported with documentation out of 145 overall cases from 17 countries. And again, we see a very wide distribution, but the important message here, mostly mild cases, very few needing hospitalization or ICU care. This is just some detail about that. I just point out here that the majority of these cases are mild. The majority of these cases have been in people with well-preserved lung function, over 70% predicted. We see a high representation of people with coexisting diabetes and overrepresentation of transplant recipients. Stands to reason. Very few that need oxygen support, but those that do mostly do well. A few patients requiring ICU care and the modalities associated with that, and an outcome here of recovery in the vast majority. So my last slide here, just as a way of saying we've got a whole lot to learn. We don't know much about the science of COVID as it applies to cystic fibrosis. We don't know how well CF people express or don't express the receptor. We don't know how that receptor interacts with CFTR or ENaC. We don't know what the implications are in the generally hyperinflammatory environment of the CF cell. And we don't know much about the implication for healthcare at this point. We know that centers have gotten back to restarting visits. A lot of these are telehealth visits. We know that some of the procedures have migrated to home testing, like home spirometry. We don't know how yet that best integrates into overall care going forward. We don't know how the social frictions in our society, like polarization, vaccine hesitancy and skepticism, conspiracy theories, how that's going to play out, how that will protect or not protect our community. We don't know much about the role of economic insecurity, access to medicine. So far, at least the CF-specific drugs seem to be in good supply. We certainly do know that clinical research and trials have been adversely affected, many put on hold. Some are getting back on track. We don't yet know with the spike that we're experiencing now, how that's going to affect people with CF. Are we going to be in danger as CF community in terms of triage in the ICU? We hope not, and there's certainly been some publicity about that. And finally, maybe the most important question of all, are enough CF patients going to be in vaccine trials to know if this vaccine, whichever emerges, and I think there'll be more than one, are going to be safe and effective in people with CF? And we really don't know where the CF community is going to stand in the queue for getting the vaccine.